but you've also talked about things like inlays. So what would you suggest, and like minimally invasive dental surgery, what would you suggest to somebody that has had a filling that's failed and they're running, seriously running low on options at this point?
Okay, that's a really good brief, and I feel a really good starting point is to be prepared to have a conversation with your dentist, and not just have a one-way conversation where you get told what you need. Dentists don't really like it, but the right dentist for you will be amenable to the questions and the potential of adapting to the questions that are asked. And the first thing I've always loved to say to patients is that coming to a dental practice like ours, or seeing a dentist like me, and I'm really not here tonight to promote myself, I'm really here tonight to promote hopefully your listeners' dentists, or your listeners to find a dentist that will be worth traveling to if they can't have these quality conversations with their current dental practice, or if they don't even have a dentist at the moment.
Right, we're back. This is episode 37 with Marc Mortiboys. I've been away a little while. I think I explained this in one of my last interviews. I broke my my MacBook, sorry. I broke the screen, and it took forever to get it fixed. So I've just been sitting and chilling and waiting for it to get fixed, and then life's been a little bit busy since getting it back, which was probably a few weeks ago now. But yeah, very fortunate to be able to get Marc back on the show. What we've done, I've explained it in as we go into the interview, but we're going to break this into 2 stages. So stage 1, essentially, as the title says, how to stop the death spiral of a tooth. So essentially, what we've done, we've covered in a few of the other interviews how to avoid cavities and how to potentially reverse cavities. So watch them first if you're in the early stages of any kind of dental issues. If you've already had fillings, or you have been told you need fillings, or you believe you need fillings, and you do go and get some fillings, and the fillings fail, that takes us to this point of mine and Marc's conversations. And basically the minimally invasive options that are available, and how to potentially save a tooth if you've got a crack or a break, a structural break, or even if you're told you need a root canal. So in this interview, we discuss really plausible options that you can take when you're in this state of kind of fear and anxiety, when you're sat in the dentist's office and you feel like you have no other options. And in part 2 of this series, what we're going to be discussing is cosmetics. This is the one I'm really interested in. You see a lot of people flying to Turkey getting their teeth done. So I wanted to discuss with Marc, look, what are the fears, what are the potential problems that can arise from this type of dental work? Is it necessary? If you are going to get any kind of cosmetic dentistry, where should you go? What kind of materials should you be looking at? And we're going to discuss all of this, and that'll be my next episode that I post. So as usual, please like, share, subscribe. I'm really happy to be back. Hopefully you enjoy the show, and yeah, we'll speak soon.
Right, so Marc, it's good to have you back again. It's been a little while. We've done 2, I think it's fair to say, pretty heavy interviews. You've just mentioned to me then, I mean, I was going to go in for the 3rd, which is going to be heavy, but you've just given me a really good idea, and that's to break this conversation into 2. So if we start with the first point that I was mentioning, which is essentially when, you've got a tooth that, say, had a filling or a crack or a break, and your next choice essentially is like a root canal, or, it kind of gets down to that path. And then the second part of this show, we'll talk about the cosmetic side, because I'm really interested. It's become such a popular thing for people to get cosmetic dentistry, veneers, composite bonding, etc. But a lot of the time they do it without actually needing it. So yeah, if we can go into that on the second part, I'd love to hear you on that. But let's start with, of course, the first 2 we spoke about, like cavities. Can you reverse? How do you reverse cavities? How do you reverse gum disease? Let's say you're in a position where you've had a filling, and now the filling's failed. Sometimes you can have another filling, but obviously they dig a little bit deeper, which of course is going to compromise the structure and the strength of the tooth. When that fails, you're kind of running low on options. So you've mentioned to me before, of course, a lot of traditional dentists would go for a crown or a root canal, but you've also talked about things like inlays. So what would you suggest, and like minimally invasive dental surgery? What would you suggest to somebody that has had a filling that's failed and they're running, seriously running low on options at this point?
Okay, that's a really good brief, and I feel a really good starting point is to be prepared to have a conversation with your dentist, and not just have a one-way conversation where you get told what you need. Dentists don't really like it, but the right dentist for you will be amenable to the questions and the potential of adapting to the questions that are asked. And the first thing I've always loved to say to patients is that coming to a dental practice like ours, or seeing a dentist like me, and I'm really not here tonight to promote myself, I'm really here tonight to promote hopefully your listeners' dentists, or your listeners to find a dentist that will be worth traveling to if they can't have these quality conversations with their current dental practice, or if they don't even have a dentist at the moment. And that is really to just find out if the situation is, there is a potential to treat it more minimally, meaning with less dental destruction, with less what we call in the profession enamelectomy. Ectomy means remove, enamel is enamel. So with the reduced amount of enamel reduction, is there a possibility that the dentistry that's been recommended can be done that way? And there's a term in dentistry that's called minimal invasive dentistry, MID, and that is a term that's very similar to keyhole surgery in medicine. And a few moons ago, keyhole surgery in medicine was a new thing, and now it's pretty much standard. You see heart operations done with cameras and tools put through veins, especially through the leg, the artery or the vein in the leg. And by doing it that way, you're not having to cut open the body and cause more stresses on the operation and on the healing processes. And the same with dentistry. The more we dig out of the existing restorations and the enamel, the more chances there are of creating irreversible damage. And what I mean by irreversible damage is inflammation to the nerve system of the tooth, where maybe a day or two later you just get a toothache from the procedure. And then that forces the decision, do we now take the nerve out, or do we now take the tooth out? And this tooth could have been asymptomatic before treatment. A lot of dentistry is done from diagnosis on an x-ray, where we see decay under a filling, for example, or alongside a filling. And the tooth is really comfortable. And a lot of patients say to me, but it doesn't hurt, so why do we need to do this? And it's really reassuring for me to pass on to my patients when I can say the risks of damaging the nerve are minimal if we do this minimal procedure. And if we go straight to just digging the whole filling out and doing big, deep dentistry and maybe then crowning the tooth, we're just adding more chances of inflammation that are potentially irreversible. Most of the time, in clinical practice, even deep dentistry can be reversible. Just give it some time. It may hurt for a day or two, and with anti-inflammatory, either medication or diet, we can calm many teeth down, but there are numerous teeth that unfortunately do not survive that kind of process. So that will be the first tip for your audience or our listeners tonight, is to have a conversation and say, can this treatment be done minimally? And if you're getting a cagey answer, don't be afraid to go and get a second opinion. Okay?
Yeah, no, I'm with you. What do you think of, like, say somebody has a filling and then they have like a small cavity behind the filling? Would you say that can be fixed from within, or would you say that needs drilling and pulling out and redoing?
So the simple answer is, we know that tooth decay can be reversed. It needs, in my world, to be done under incredible supervision, at least with a dental hygienist alongside a dentist. And maybe it can be done with online dentists now. There's many dentists guiding and helping, like a coach, helping patients online with x-rays being sent to them by email, maybe sometimes a little video being sent. So we can help people online and videos, just like GPs are doing in the medical world. But it is still easier if we can actually feel and see clinical situations 6 months on, sometimes even 3 months on, and up to a year on, to see if we're winning this remineralization journey or not. Because if we're losing the remineralization journey, then what do we do? Do we just keep on hoping and praying, or do we just nip it in the bud? And I think if we're losing, personally, I feel like we should, at least with minimal invasive dentistry, do things to either stop the decay or slow it down. And that's when I'm very comfortable drilling a bit of tooth decay out. I know there are people out on different kind of social media pages who are really anti anything, and they keep preaching just remineralize. And I think that's fantastic if you can win at that, and you're prepared to be that superhuman individual that makes incredible amounts of lifestyle changes and has a bit of luck on their side and can turn things around under supervision. Because if you're not having it under supervision, how do you really know this is actually working? And how do you know that you're not going to end up losing a tooth rather than just a filling? So that's where I would get worried about people who want to remineralize without supervision, is they could end up losing a tooth when maybe with just a renewed filling, they could have kept the tooth. And a lot of streetwise dentists will know how to repair a failing filling or clean out some tooth decay around a filling, especially if it's perimeter decay, like ditching that's around the edges. A bit like when silicone starts to wear out in kitchens and bathrooms. We don't take all the tiles off, do we? Unless you want a different color change, or if you're really worried about the tiles and maybe rot underneath the tiles. But most of the time, it's just a silicone change. So that's how I explain it to a lot of patients, is that we can repair failing fillings with the more modern filling materials, which are basically a resin that's filled with quartz crystal. So all these white fillings are fundamentally a quartz crystal with a bit of resin binder that you can then just seal failing edges around fillings. And if you're needing to drill some of that filling out, you can still repair with these materials. That said, most dentists don't like doing that. They worry that they may leave some tooth decay behind, and some of them are purists and say, no, I have to have everything out and start all over again. So that's why you need to kind of maybe even have a discussion with your dentist first of all and say, look, how can we reduce the risks of digging out all the filling, getting closer to the tooth nerve, and increasing the chances of root canal problems? And even if it means you have to sign a waiver, just have an honest conversation with the patient, because we are under very strict guidelines, or we feel we're under very strict guidelines from our governing bodies. And unfortunately, that fear of being sued or litigated kind of drives the decision for a lot of dentists to actually know we're going to do this by the book, XYZ, rather than saying, okay, I'm open to ducking and diving with this situation to reduce the risk of root canal. But you've got to realize that this is not 100% PC seen as gold standard dental care. And if you have that honest conversation and you say to the dentist, look, I'm prepared to take the risk here, you don't have to take any risk, then if you've got a sensible streetwise dentist, I feel confident that they will be open to the possibility of repairing a filling rather than doing a new filling. But you do, unfortunately, have to have that conversation, which can take a bit of time, and not every dentist will be up for that. You may have to then go and inquire amongst friends and family who's got a chatty dentist, who's got an approachable dentist. I tend to call it all the A's, the affable ones, the amiable ones, the approachable ones, that have that personality to be on your side, rather than just that, I'm a doctor, I'm a dentist, I tell you what I'm doing, you don't tell me what to do. Does that make sense?
Yeah.
So
No.
yeah, and not everyone has that dentist, and they may be the best dentist on the planet, but they will not be flexible. And sometimes in these kind of situations, and the kind of patients that will be listening to our kind of podcasts, they're going to be the more sensitive and more questioning of authority. So ultimately, I think you do then have to kind of attract the clinic that will be matched to your needs. And there is an ever-growing movement now of holistic dental and medical practice. So it's just a matter of using search engines and not necessarily going straight into the first clinic you find, but go and have a little look around, meet the team, have a chat with the reception team, and see if there are people who are open to this kind of thing, and maybe even get some photographs of your teeth taken and have a conversation before even jumping in. So I've just been recently doing a series of videos on YouTube, and I'm on number 6 out of 8. And these are kind of like data gathering tips. You know, what's the kind of data that you want before you make a decision? And one of them is photography for sure, and another one is X-ray for sure, and there's numerous others. So all the audience can listen or watch these videos on YouTube and on social media sites after this interview. But I'm kind of arming our readership, our listeners, to kind of get streetwise and know what to ask for, and not to really get naked on that first appointment, if that makes sense.
Yeah. If you after this call, if you send me a link to that, I'll post it on the show notes.
Fantastic. Yeah, great.
Sure, people find that. Before we move on to the dangers of and you know how to try and avoid a root canal, I wanted to ask, if you do have a cavity that's remineralizing. I actually heard a dentist, I forgot her name, it's an American dentist, and she says that once a tooth has remineralized, like a broken bone essentially, when a bone fixes, it fixes like almost, it mineralizes even stronger, so it becomes even stronger. Do you believe that, or do you think it could always be slightly questionable and you've got to kind of keep an eye on it forevermore? What's your view on that?
Yeah, so I don't know where she's getting that kind of confidence to say that. Most dentists will see really hard, dark dentine when you take a filling out, and if that dentine is rock hard, then we call that remineralized secondary dentine. So it's healed dentine. Whether it's harder than original dentine, I don't know, but I personally don't know. But it's rock hard, so it's just as hard as dentine. Whether it's actually any harder, debatable. But the good news is, it's hard enough to leave. And that's really critical, again, with minimal invasive dentistry, is why are you drilling out rock hard dentine just because it's brown? And I think that's, again, we're living in this age where we have been taught to be purists, and maybe we haven't got all the modern knowledge and modern education, even though we are meant to. So there will be dentists who just think, oh, it's still brown, I'm going to keep drilling it away until we're down to the kind of yellowy white color of dentin. But here's the other good news, is that there's plenty of research. I mean, I was trained in the 80s, and I was even taught this in the 80s, that if you go around one of these brown patches, so you isolate, so you have clean, yellow, rock hard dentin all the way around a very brown patch that's also slightly soft, meaning it hasn't fully mineralized, you can remineralize that by putting a special product under the filling. And it's a very highly alkaline, calcium-based filling. It's mainstream knowledge. All dentists have been trained to do this. So one hopes that is being done in clinical practice. And you either then go back in 6 months or a year or a couple of years later and just look again, or just trust that what you've done is going to work, and then you monitor it on X-ray. So one of the challenges with secondary dentine healing is sometimes it doesn't look on X-ray as fully healed. So it may be fully healed, but you still see these little dark shadows. And so something I teach my team regularly, especially my nurses, is that because I've been in dentistry now over 40 years, and in my current practice over 25 years, I've got X-ray evidence where I'm remineralizing or arresting decay with radiographic evidence every year or every 2 years, maybe 10 years ago. I've got cases where I've got 5 to 8 sets of X-rays proving that what looked like we should drill 5-10 years later looks exactly the same. So it must have stopped, but it hasn't got any better. Does that make sense? It's kind of still looks like a shadow on the X-ray.
Kind of arrested and just sort of sat there.
Dormant, like a volcano. It's got dormant, and that's maybe where we get nervous, because a bit like volcanoes, if it has erupted, we worry that it might erupt again in the future. But all I say to people is, look, you've got a risky situation. You just need regular screening, and we just agree the regularity of that screen, like an X-ray screen or a visual screen, it's rarely more frequent than 6 months, and it's rarely longer than a year. So somewhere between 6 and 12 months, we just say you've just got to commit to this, because if you don't, you could be foolish and you could get into trouble.
Yeah, that's kind of where I'm at with one of my things is you know, every time I've had it looked at, it's fine, but it's like I'm just going to check it every year. But then I don't want to get X-rays all the time. So I was thinking I might buy a thyroid guard. So because I do worry about the thyroid with these X-rays. Would you recommend that, or would you say just don't worry about it?
Yeah, I think it depends on how many X-rays you're having. I mean, are you a sickly person that needs chest X-rays because you got asthma or
just
kind of chest infections? But if it's just a dental X-ray, one single X-ray, and I would say make sure you go into a clinic that's modern and digitized. I mean, there aren't that many undigitized dental practices anymore. They've mostly been upgraded now to high-tech modern digital systems. But one X-ray is equivalent, digital X-ray is equivalent to 1 hour of flying. So the dose of X-ray when we're up at 20,000 feet or higher, with the ozone layers being kind of more depleted, we do get some radiation from things like flying. So if you're worried about flying and you're flying, X-ray, dental X-ray, and you're flying to America 2 or 3 times a year, or you're flying back and forth to Scotland on business trips on a weekly basis, then I think you have to be a bit more kind of like questioning your understanding. And I think a lot of that fear comes from not really knowing what the dose is. So thankfully, dental X-ray is the lowest dose. You do make a very good point, though. The beam does beam potentially through the jaw, where it has to go through the jaw and the teeth, and some of that scatter can go near the thyroid. So if you've got a thyroid issue or a thyroid concern, maybe a hypothyroidism or a hyperthyroidism, you may want to protect your thyroid. But here's the kicker. And you may, if you're old enough, you may remember that as a child, you would have had lead aprons put on your body before an X-ray. And then a scientist did some research and found that we are better off just having an X-ray and let the whole dose just go straight through our body and be gone with it and be done with it. When you put lead around the body, there is potential for scatter to get underneath the lead apron, and it kind of then traps it, so it just bounces back and forth through the body. So the consensus of that research was like, well, give patients that are really anxious about it a lead apron, but we can't support that with science anymore. So we do offer a thyroid collar for anyone with thyroid worries. And then at the same time, it's kind of a bit of an oxymoron because we don't believe it works. We've actually got science to say that you're probably more at risk. But if it puts your mind at rest, then so be it. But I tend to put my patients' minds at rest by just educating. And then I offer 2 ideas. One is the homeopathic idea.
There with them. I'll stand with you. I'm not worried about it.
But the great one is, whether you believe in homeopathy or not. Most people don't really believe in homeopathy, but they'll take arnica because it seems to work for inflammation. And there's a great homeopathic remedy called Rad-Brom, which is radium bromide homeopathic, and that's been used for over 100 years in the homeopathic community for neutralizing the frequency of radiation. Right, so it's just like an anti-frequency, and that's really what homeopathy ultimately is just the opposite wavelength to whatever is seen as a poison or seen as an issue. So I'm very comfortable with that. You can also up your pectin levels. That came out of Chernobyl when Chernobyl kicked off. I think was that the 80s or 90s. I don't know. It was certainly a good 20 plus years ago. All that radiation in Russia, and they had amazing turnarounds by using pectin, which is basically the kind of main ingredient of a lot of plants and fruits, especially apples. So what's the expression? Apple a day keeps the doctor away. Might even keep the dentist away as well, I often say.
Wow. Would you say iodine as well, or?
So iodine, I didn't mention iodine, but iodine's another one of these materials that could have benefit but yeah, I don't want to kind of go on too much about radiation. Radiation is such a big subject, but for a dental X-ray, I don't know if you really have to kind of really be that worried about taking all these precautions for a dental X-ray. So
good advice there. And also, you're not, it's not, you're maybe helping with people that are a little bit worried about it. So no, I'm glad I asked, but you're right. If we could spend an hour on this. So
yeah, that is a big subject, and I think at the end of the day, we've got to decide the risks versus benefits. That's what every dentist will say. Every doctor says, well, what's the risk versus the benefit of taking an X-ray versus just guessing and praying that something's not changing? Because often you can't see this stuff clinically. it's under a filling or it's under a crown. And sometimes you can feel it with our instruments, but most of the time we only diagnose it from an X-ray image. So yeah, it's a challenge. It's a clinical challenge for us, for sure.
Right. Next point: root canal.
The dreaded root canal.
Dentist says, look, essentially you've got an infected nerve. What we can do is we can either give you a root canal, or I guess you'll have some other suggestions, but my understanding is root canal or have it pulled out and get an implant. It seems like that's kind of, that's the T junction when it gets to this stage. Is there anything else you could advise, or is that correct? And if so, what would you recommend your patients to do?
Okay, so I think off air when we were chatting before we went on, I kind of wanted to get across tonight that there is really no obvious black and white answer to most people's treatment planning. The fundamentals of treatment planning need to take in a lot more than just the clinical situation, but that is still the most important aspect. But I think we've got to look at many things. First of all is the severity of pain. First of all, so I've seen many people come to me and colleagues who've been told they need root canals, and we've looked at the X-rays, we've listened to the symptoms, and we've said, you know what, why don't we just give this tooth a bit more time, and let's see if you still need an X-ray in a week or two's time. And if the pain is not excruciating, and you're not swelling up, and there's no sign of infection, then maybe there's a possibility this can reverse. So we've seen many situations where time, and you know what I'd call it, TLC, which is tender loving care, where you back off chewing on that tooth and putting hot drinks and cold drinks on your tooth. Can this inflammation or possible infection actually be just quiesced or calmed down and ultimately then reversed? And we've all seen that if we've lived long enough and done enough sport in our life. We've done that with twisted ankles, with pulled muscles in our backs. We think, geez, have I broken something? And you're hobbling along, being really kind of gentle on an ankle or a foot. And then lo and behold, a week later, you're back playing that sport, or you're running, thinking, geez, a week ago, I couldn't have done that. So something clearly was very painful and inflamed, and the body sorted it out. And there's so many holistic practitioners who say that so much can be reversed, but are we prepared, one, to be patient, and two, to do the work? And that's really, I think that's where the questioning needs to come in. Are you wanting a quick fix? Are you prepared to come back and have a review, or do you want me to make a decision here and now? I mean, no dentist pretty much nowadays pulls the tooth out on the day, because we've had so much what's called buyer's remorse or clinical remorse, and we can almost be sued for that, because we're qualified consent really takes at least 24 hours, to make an irreversible decision, like taking a tooth out. I suppose if a tooth is shattered in a road accident, that's a slightly different situation, but a tooth that's starting to grumble or starting to hurt, and someone comes in and says, oh, please, I just want this tooth out. But not many dentists will do that anymore. We'll give palliative care to help someone make a decision overnight, if that makes sense. So they wake up in the morning then going, yeah, I still want that tooth out. Or, you know what, that painkiller's actually calmed things down a bit. I stopped biting hard on it. I stopped chewing on it. I had tepid drinks and foods for 24 hours, and things have actually calmed down. And I've even taken the odd anti-inflammatory tablet, for example, like an ibuprofen, aspirin, if they can be tolerated. These anti-inflammatories can reverse some of these symptoms. If it's a true infection, what tends to then happen is the infection becomes chronic rather than acute. So at least by taking some time, it's taken the urgency away. So this goes back to now what I was saying earlier on. What are the other factors? Now, if someone's about to go on a long flight, maybe say flying to Australia or Asia, and it's a 20-hour flight, do you make a different decision to if someone is actually not going away at all for a good month or two, and they live just down the road? That's a lot easier for that patient to say, you know what, I'm happy to give that a week. Let's see what happens in a week's time. Versus the person flying the next day says, geez, you've got to do something because I'm flying tomorrow. So most dentists will give an antibiotic and some strong painkillers and say, you're going to have to deal with that in Australia if it's still kicking off. So you can see what I'm trying to say here is that there isn't a black and white answer to a clinical situation, there are other circumstances that needs to be followed. And then you've got to then start looking at social history. You've got to start looking at nutritional status, emotional status, and many other factors. And even up to a point, if you're not going through free NHS care, with income support systems in place, if you're having to self-fund the treatment, there's also got to be that kind of discussion like, well, what can you afford? It sounds like the American system, and sadly it's getting a bit that way, but at least palliative treatment is not that expensive. It's the treatments to keep a tooth, or if we take the tooth out, to then rebuild the space, those discussions need to be had ideally before the treatment, because there are consequences from every decision, and some of those consequences are significantly economic. Does that make sense?
Yeah.
If someone says, oh, you're going to have to have a dental implant here, which is probably not true, because before dental implants there were at least two options for many people, which were dentures or bridges. Sometimes those options aren't available just for that clinical situation, but most of the time one of those two options is still available, but it's not seen anymore as the gold standard. So often the gold standard tends to get promoted first. It's a bit like in car sales. I don't know if you've ever been sold a car or listened to a salesperson. They tend to give you three options. They tend to start with the top of the range, then the bottom of the range, and then the middle range is generally what most people go, unless they're really up for the top of the range. So if the dental situation can offer three options, which usually it can, then a lot of people will still go for the middle range. Some will go for the top range, and unfortunately plenty go for the bottom range, because the economic situation of this country, let alone the world, is atrocious right now. And unless the dental practice can offer payment plans, even for a small amount of treatment, say like a £500 piece of treatment, that could be spread out over 10 months, interest free at £50 a month. That would make a decision-making process a lot easier, wouldn't it?
Oh yeah.
So, because a lot of people make the decision out of purely economics. It's a bit like when you go to a restaurant. Are you looking at the right side of the menu or the left side? Right side being the prices, and are you just going for fish and chips because that's that price, or are you going for steak and chips, which is twice the price? And that's the same with dentistry. Things are twice the price. A filling is one price, and a crown is another price, or an onlay or an inlay could be twice the price, if not three times the price. So price does come into dental planning if someone is not really communicated to effectively. And well-run dental practices will make sure there's time for that. And they'll even have staff trained called treatment coordinators. And if it can't be done there and then, it really should be done at a follow-up appointment.
Yeah. Just going back very quickly, and not to spend too much time on this, but you mentioned about if you're at a point where root canal is potentially needed. I know Remel Nagel talks about, he basically says exactly what you've just said. Look, take your time, sort your diet out, and you can actually reverse it and fix it. Are we talking reverse it so there's no more pain, but that tooth is always now going to be compromised? Or are we talking you could potentially reverse that all the way back to some sort of long lasting healthy tooth?
Really good question. And every dentist knows the real answer here. It's just something that we don't like to monitor. And that is, we've seen many patients over many years, when we take the bigger x-rays, even sometimes the small x-rays, where we take a big x-ray where you have a panorama image of the whole jaw and have maybe 24 teeth on a film, and these are people being screened without any discomfort whatsoever. They're just coming for a check. And then we will see dark shadows in the jaw bones where teeth have died. And those shadows, we don't know if those shadows are dormant or are still growing. And what those shadows are signs of chronic infection in the bone. And the traditional term is a cyst. So they've become cysts. And all a cyst really is a gelatinous cellular wool sac of chronic inflammation. So the bone has gone soft. And there are people that are saying that with the right remineralization, with the right nutrition, and the right environment, that maybe some of this can be reversed to the point where where the nerve dries out to the point and disinfects to the point where the body's self-regulatory mechanisms can reverse all this. But it's a really risky game to play on one level. You need to have very educated patients on board. So if someone's not educated and is really a bit of a hedonist and not really looking after their health, then those people are either better off having the tooth removed, or they have a root canal treatment. And occasionally we recommend that the cyst is removed from above the root. So we make a little incision in the gum, maybe a centimeter away from the tip of the root, and just remove the cyst and seal up the connection between the tip of the root and that cystic area. So it becomes then more of an oral surgery rather than a dental surgery.
Yeah.
But doing these treatments saves people's lives, because you can imagine upper teeth in particular, especially molars and premolars, those roots are sitting either in our sinuses, around our sinuses. If you just do the simple measurements with your fingers, tip of a root to your eye is probably no more than a centimeter. To your brain is maybe 2 centimeters, an inch. So you don't want uncontrolled infections potentially growing into sinuses, into eyes, and into our brain. And with the current, what's the right way of putting it? Current autopsy studies, that science is now really kind of proving something that was kind of discussed over 100 years ago, which is called the focal sepsis theory, where microorganisms from the mouth, especially from the jawbone, are now being seen in all our organs in autopsies. Doesn't mean that they necessarily were killed by those organisms, but what if we start seeing these organisms in hearts, in brains, and we're seeing more and more cardiac concerns. We're seeing a lot of dementia. So scientists are now extrapolating that these organisms, these oral organisms, could be one of the major contributors to these now well-known diseases, because they're also getting into livers and in kidneys and into maybe where we produce our insulin, for example. Is that one of the causes of diabetes? Why is it just sugar consumption, or is it now oral bacteria getting into these vital organs that could be then contributing to the disease process? And that seems to be quite significant now, and it's almost like a mantra. Is like if you go and see a cardiac surgeon, because you're going to need some kind of valve replacement or some kind of cardiac operation, most cardiologists will say go and have a dental check now. So it's become pretty much mainstream even amongst the medical fraternity, this oral general link, oral systemic.
My granddad, he had a triple heart bypass and he had to get 3 or 4 teeth removed.
Oh wow. Okay.
Yeah. So it was, when was this? This would have been about 6 years ago. No, it was a bit longer, maybe about 10 years ago.
Wow.
But I haven't actually, since I've learned about this topic, I haven't quizzed him on it. Maybe I should, but I remember specifically he said that. So it must be something that is like, at least semi recognized.
Yeah, and that again kind of confirms what I was saying earlier on, is that that's got to be a key part of the questioning process. How much time have we got? Can we see if we can slow down the growth of this cyst? Can we actually arrest this cyst? Can we even give it time to find out if it has already arrested? You'll only find out by taking an x-ray 6 months later or a year later, or even having a screening 6 months or a year later. So if someone's young, fit, and didn't know they had it, and they're comfortable with the idea of having it observed, not ignored, but just a new booking made 3, 6, 12 months later for a new x-ray or a new review, and then to call if things go wrong, things start to become symptomatic, then we don't hang around. But if you're in this grey area, which clinical practice is most of the time a grey area, unless you work in a practice that just deals with emergencies, most general practices have a lot of what I call grey needs, where do we have to make a decision today, yes or no? Unlikely is the majority, but we tend to kind of put scare tactics in, because we have a lot of patients who just are fly-by-nights, who don't take their oral health seriously. So we often have to say, look, we need to get this sorted out. And if you're a patient that's a diligent, regular attender with evidence of maybe 5 years, 10 years of diligent revisiting to the clinic for examinations, and even seeing hygienists and getting the benefit of our preventative training and preventative skills and knowledge, those patients deserve a different kind of treatment planning to the patients that are just turning up because they've got a toothache, if that makes sense. So it's all about, are you an A&E patient, or are you just someone who wants to be ahead of the game and wants to be screened well before problems are arising?
Yeah. Do you still give people root canal if that is sort of all that's available on the menu?
Okay, so the first thing I'll add to the whole debate about root canal, because if you go down the rabbit hole of root canal, as I'm sure most of our listeners will have done or will do after this, you'll think it's the worst thing to ever consider for a tooth. And the good news is that I just don't see that as the truth. The real truth is that a well done, skillfully treated tooth on a patient that has the ideal biochemistry and nutrition and health status rarely has an immediate problem with the root canal. Root canals can harbor bacteria, and research says it actually it just does. It still harbors microbes inside the microtubules in the dentine. And ultimately, if that is a septic, has a potential for being septic all the time, it's then dependent on our immune system to whether we can control that level of microbial activity. Because there are plenty of people who can survive smoking, can survive heavy alcohol drinking and fast food eating and still live to 100 years of age with not a lot of disease. And then there'll be some people who are really squeaky clean with their diets, with their lifestyle practice, and they seem to get ill quite quickly and easily. So their immune systems, for whatever reason, whether it's genetic or whether they've got some toxicity, or it's maybe emotional, they have a lot of stress, they just seem to be much more prone. So because of that, I think the baby gets thrown out with the bathwater. Root canals get accused of a lot of diseases and disorders. That said, when you go down the rabbit hole of researching this stuff, and Weston Price did a load of research on this stuff, he kind of really sort of supported the idea of focal sepsis theory. And then he, back in those days, was actually suggesting that we are probably better off with having those teeth removed, if not all our teeth. So there was a phase when, especially after the war, when we were all undernourished, or whoever lived through the war was undernourished. We have grandparents now and other family ancestors alive or not with us anymore. A lot of them had their teeth removed because one or two may have been infected, but it was like, well, we're taking a couple out, so let's take them all out because there are all these risks. So we don't want that happening again. And sadly, I'm starting to hear that again. People are going to clinics all around the world just to have either some teeth removed or all teeth removed because they've got a number of root canals. But the root canals are not hurting. They look okay on x-rays and they're actually healthy. So those people I get more nervous about. The people that then you'll equally hear stories of someone who's got an incredible illness, goes to a biological dentist somewhere around the world, have one or two teeth removed, sometimes having some dentistry done afterwards, but ultimately it's about having the tooth removed, removing the source of infection, not just the tooth, but then the bone as well that's got infected. So there are protocols to reduce the risks of leaving infection behind, and there are many of those, and we could do a whole podcast on all those protocols, from using ozone to mechanical techniques to clean the bone, to maybe use what's called PRGF, which is protein-rich growth factors, which are taken out of our blood. So you've probably heard of the vampire facial, where beauticians will inject PRGF into the skin of the face just to kind of make it look more youthful. There are these magical ingredients within our blood that help. They're kind of like stem cells, and they kind of help regeneration. So there are dentists who will do that to reduce the risk of infection recurring after having cleaned out a root canal treated tooth, for example. So there's all these extra protocols, but ultimately the bottom line is we want the tooth out, or when this tooth gets removed, you hear these stories of people's health just coming back to normal. And then we're talking major health conditions that are reversing from a very wise dentist or maybe a team of clinicians who've kind of diagnosed that a particular tooth that had this infection, and it could even be a buried wisdom tooth, for example, or a semi-buried wisdom tooth, an impacted wisdom tooth, and the tooth removed, infections cleaned out the jawbone, and these horrendous health problems disappear. And that's magical and that's wonderful. And I don't believe it's all psychological. I do believe there is a huge element of the physical. There may be some of the placebo effect, who knows? But ultimately, I do believe that there's a lot to do with the immune system suddenly functioning better from having a tooth removed that's kind of draining the system, because these things are leaking kind of nasties into the body all the time.
I think that's the thing with that, though. Sorry to interrupt.
No, you go for it.
These people that obviously end up with some chronic illness or disease or, you know, whatever it is, and then they realize it's the tooth that's causing it. I think that just goes back to what you advocate for, is like regular checkups. Because if and this is essentially leads me to what I'm going to suggest I would do if I was in this situation. I would do everything in my power to avoid a root canal.
Yep.
But if it was the last sort of thing I could do without having to pay a load of money for an implant, and I'd weigh up the two, do I just pay for the implant or do I get the root canal? If I got a root canal, I'd try to use someone like you. And then what I would do is I would ensure that every single year I get an x-ray and I check it.
Yeah.
And then once it starts to become problematic, then I'd rip it out and then I'd clean it up and then I'd do an implant. Would you suggest that's probably the best way to deal with this? Is don't just get a root canal and dip off again for another 10 years. Do it if you have to, but do a yearly checkup and keep an eye on it and continue with like some sort of oral health protocol and keeping a clean diet and ensuring that you're doing all the right things to get the right vitamins and minerals. And I guess the healthier you are, the healthier that root canal will be and the longer it will actually last.
100%. So all those things are spot on. And then you also got to add on, and this is where we're going over the next 5-10 minutes of the conversation, is when do we just bite the bullet and cut the losses? Because there's another factor that we haven't addressed yet, and is what is the structural status? So it's a bit like a car engine or a clutch, or even a house, you know, where, yeah, it can be patch repaired and we can do this, we can do that. But sometimes we have to make a brave decision and go, you know what, time's up. And in dentistry, for me, it's when it's got gum disease as well as a root canal problem. So it's really hard to keep clean. Maybe there isn't much tooth left. So after the root canal, you've then still got to do all this complicated, expensive dentistry that actually, when you do the maths, could be similar or slightly cheaper or slightly more than what the alternatives that we've just discussed, like dental implants. So that is a huge decision maker that a lot of clinicians are now having those discussions with patients and just saying, look, I can't guarantee this is going to last more than 1, 3, 5 years. So why are we trying to save it? Now, if the reason to save it for 1, 3, 5 years is it buys us some time, and right now is not a good time to be doing things. Say you're going through a divorce, going through moving area, many social circumstances that are not ideal to make an irreversible decision, where maybe there's a gap, maybe it's going to be uncomfortable visually as well as physically. So those factors have to come in, but it's ultimately about how restorable is that tooth as well as the root canal, because the root canals most of the time are straightforward to do. It's mainly what next. So if the tooth is really solid and there's a lot of your own tooth left, then it's a no-brainer. But if it's kind of a crumbled little tiny bit of tooth left, and to restore it, you've got to do all this high-risk dentistry that rarely lasts more than 5 years. You've got to be then brave and say, look, time to get it out. Unless you're one of these people, and I'm one of these people, and the tooth really has to go, I'll definitely get it out. But I'm kind of confident that within the next period of time, and it could be as quick as 5 years, it might be as long as 10 years, but the stem cell research, right? The stem cell regeneration movement is only around the corner. And I have been saying that for 10 years, but I know we're 10 years closer, and we can't be another 10 years away from it, where we can regenerate organs. There's plenty of evidence. It's probably been going on since World War II days with Mengele and all the kind of SS crowd that were playing around with genetics back in those days. But certainly in the modern era, there's been a lot of research. We just don't know when we can say now is the date that we can make or regrow a tooth, but it's not that far away. And if you take a tooth out and do nothing to that space, a lot of the bone does shrivel and atrophy and shrink. And also, if you then put an implant straight into that space, hopefully that implant lasts you for the rest of your life. So you don't need to worry about having had a stem cell tooth. But if you're the sort of person that would rather not have an artificial body screwed into your jawbone, and you can wait, you might be one of those people who will sit on the fence and just keep a dead tooth under regular investigation and screening, like we talked about, for the following period of time until that technology is around the corner. And then if you can't wait any longer, then take it out. So there's so many factors if you have that kind of dentist that thinks like that, because they're not. I'd say we're not trained to think like that. Quite frankly, we're trained as very black and white. You've got a problem, here's the solution. Not, well, we could see what happens in the future. So you do need open-minded dentists. And I wouldn't say just open-minded dentists are biological or holistic. There are plenty of mainstream dentists that are open-minded and may think like that. But at the same time, you won't know until you have that conversation with your dentist, and you won't know if you don't get a second opinion. So I'm not really on the show to make sure everyone has a second opinion. But if you are questioning the options, or if you in your gut instinct is just like you feel something's off, and then I think it is really about getting a second opinion, and second opinion with someone who does think outside the box and has experience. So that's why I'm on the show tonight, because I am one of those characters, and I'm very comfortable giving guidance online to people. I just won't be the guy doing all the dentistry for anyone, because I've got other missions in life, and one of them is to be an educator online. So hopefully some of your audience will feel comfortable to ask me questions, and some of it I do free of charge for a simple bit of guidance. And then if it's a complicated rethinking of a treatment plan, then I just charge an appropriate fee, and we discuss that before we go into it. So I'm very happy to discuss that in the future.
Perfect. On this, so part one, let's call it part. Last bit before we move on to the second part, which will be cosmetics. So crowns. Do you mind just giving us an overview of crowns? And I guess if we just kind of break it into a couple of sections. So do you recommend them? What's the dangers? Can they cause other issues with other teeth? Or could it be a good thing to use to keep the root of your tooth healthy until the stem cell, fillings or implants become available? And also maybe a little bit on maybe the chemical composition of crowns and things to look out for, because some people go and get silver or gold, which can maybe cause other health problems. And what's your sort of view on crowns as a whole?
Okay, great. I want to keep this short, but it will still be a few minutes, because that's a huge subject in my profession. And we've been going through a massive transformation, like the whole world. Every marketplace has had transformations, whether it's cars becoming electric, whether it's housing that's becoming more kind of quick to assemble. Dentistry's been going through this same kind of transformation with materials and attitudes and design protocols. So crowns really were the first idea to save, like a last resort, to save a failing tooth, a broken tooth, or a heavily decayed tooth, because it was ultimately a thimble of a product, and we'll go into products later, of a product that wraps around a whole tooth. Many of your audience will know what a thimble is, and it's like a piece of metal that goes over the finger to protect your finger when you're sewing. So if you can imagine like a thimble or a cup that goes over the whole tooth, but to get that to go over a tooth, to strengthen it, you've got to remove any last remaining piece of enamel on the tooth, and then you've got to reduce whatever it's restored with. So you fundamentally turn that tooth into a stump. And sadly, we see a lot of that happening in some countries around the world, and it's even getting a reputation called TT, or turkey teeth, where teeth are cut into like Dracula teeth, or even reptilian teeth, where they're kind of little tiny triangles, where everything's been removed, not just enamel, but a lot of dentin. So the more that's removed, the bigger the chance of fracture of the tooth, let alone infections and inflammations in the teeth. Because the more you remove, the less insulation we've got, less protection to the root canals. So most definitely minimal invasive dentists, and a lot of dentists, see crowns as the last resort. Is there anything else that we can do other than a crown? Because if it was my tooth, that's what I would do. That's how most dentists will think. And they would like to offer something other than just, well, you've got a broken tooth, live with that. That's not really an acceptable option. The patient doesn't want that, but the patient wants a restored tooth. So then we look at the whole myriad of options. So crown is seen as the big all singing, all dancing wraparound that's quite destructive, or very destructive to a tooth. And then the least invasive is seen as a big filling. There used to be the big silvery mercury fillings, big grey silver kind of teeth that a lot of people have. A lot of people then have them converted to huge white fillings. And back in the day, they were seen as too soft. thankfully now they're getting strong enough to the point where many people are walking around with heavily filled teeth with just big white fillings instead of crowns. And in my clinical world, I've seen many people do really well with that. It depends on many factors, from hygiene, how regularly you're attending, etc., etc. And the risks, the root canals are the least invasive because you haven't had to cut away the rest of the tooth. But what if you're worried about strength or fracturability of that tooth? And that's where often we say to patients, there are other options other than a crown or a filling. And that is where, and I'm sure that many of the listeners have had this treatment, it's where you're told we can actually make the filling outside of the mouth, and we can even design it so it kind of laminates the bite surface. So you have a tabletop of filling material and no enamel, but all you're then replacing is what was originally the cavity when the filling comes out. And that's called an inlay or an onlay. So an inlay is just going inside the tooth, and an onlay or overlay is where it's like a crown, but you haven't taken all the surrounding enamel away. So it's as strong as a crown, but as minimally invasive. And because the material is made out of the mouth, it's seen as the gold standard as in terms of strength. Because going back to materials back in the day, and still in some parts of the world and some parts of the UK, there's a decision to go for a very hard gold alloy. So it can't be pure gold. Pure gold is way too soft. 24 karat gold would be way too soft. So hardeners are put in. Some of them are questionable hardeners that have been proven to be mutagenic. Some of them seem to be good for us, like copper has its positives, but equally might have some negatives. But there are additives like palladium that have been questioned when mutagenic research is done. So a bit like mercury, there are other elements in these alloys that make crowns that people are questioning when you have like a gold filling. So not only the color of gold is kind of an issue for the majority of society. I mean, there's some people who just love it and want gold teeth, but the majority want an invisible piece of dentistry. So there's been a huge movement towards white dentistry or tooth color dentistry. And we're now in a really beautiful stage now where we can give patients almost the perfect solution, which is a man-made diamond called zirconia, and it's milled out of a block from an impression of the tooth. And for a majority of people, that can be inserted into the cavity over the top of the tooth and strengthen it beautiful, and it can look beautiful too. And before zirconia, there was porcelain, and that still exists, but we do see that material as a little bit more risk of fracture. So if you're someone who breaks teeth really easily, has that body type, that's what we call meso body type, which is more the rugby characters. You know, when you look at a rugby field, you don't see many body types other than what we call the meso body type, the very chunky, muscular and bony kind of body type. Because those people, you look at their jaw structure, they're very powerful bites. And they're often doing weight training, they're clenching their teeth and gritting their teeth. So those people tend to fracture porcelain type dentistry. And some of those people have to then have crowns, but the majority of them can have the overlays in zirconia, and occasionally they have to have it in gold, because no matter how strong zirconia is, some people are still breaking zirconia when they clench. And the only product that doesn't seem to crack is gold alloy. It might wear down over time, maybe over 10, 20 years, but it doesn't fracture. So there are numerous factors that go into the decision-making process of what material to use. And then you've got the cost factor, because with gold prices rocking right at the moment, not many people are going to be that keen on investing in gold in their teeth, even though it's not that much gold. You know, the size of filling and the amount of gold in the fillings, it's not going to be thousands of pounds just for the gold. It might be £1,000 for the actual work, but the gold is definitely raising the price. But that shouldn't be the decision-making process. It's about strengthening it, whether someone needs it because they have a bite that's just so extraordinary. You know, the really big, strong bites. Alrighty. So have I answered the question? I don't know if I've fully answered that.
Yeah, you have. That's me, by the way. I actually broke a tooth in my sleep because I was clenching my teeth. It happened over a long period of time. Mm-hmm. I noticed a very small chip is on one of my molars. So I was like, that's weird. And then about, I don't know, 5 odd months later, it's just gone. No, it was only like the corner of it. Mm-hmm. But yeah, that's and I was told I grind my teeth. You can see it on my teeth as well. So that was from years of probably stress, to be honest. I don't know, God knows, but
there are so many causes of tooth grinding, and that's another separate podcast if you ever want to do that in the future. But in the short term, as long as you've got some kind of protective guard on your teeth at nighttime, it's only really nighttime grinding that's out of awareness, shall we say, or subconscious, where we don't control the forces or we parafunction through our teeth. Daytime, most of the time, unless you're on some really strong either medications, but mostly it's seen as kind of recreational drugs that kind of switch off that kind of faculty. And then if you're raving, shall we just say, and you're grinding your teeth without any awareness, you can do extreme damage to your teeth as well when you're on recreational drugs. So you can be awake, but you're not really that awake when you're kind of participating in those kind of activities, sadly. So yeah. But yeah, in the short term, just get a guard, and then long term, look at getting stronger dentistry wherever appropriate. But maybe in your case, if it was just a chip on the corner, you might have been able to have an overlay. And there's a term now called biomimetic, which is a term that's now quite trendy in the US, where you just put back what's removed, and make it look and bring it back to exactly the same shape and size, what we call morphology, than when it originally started. And again, you're not then hacking off all that remaining bit of enamel, because the biggest downside, other than risking the root canal, is then you've got this 360-degree edge all the way around your tooth, which is a bacteria trap. So no matter how well how thin you fit that and how well you make it, there's always an artificial edge to the tooth. And that means you then got to really look at the biology of that area, because maybe a quick toothbrush will clean a tooth easily, which never had any dentistry, but a crown tooth needs a different level of care. That's like buying a supercar, right? You buy a Porsche or a Ferrari or one of these supercars, the level of care and attention that car needs compared to your bog standard Land Rover or something, an old Land Rover, for example, just doesn't need the same level of maintenance, and it's much more easy to keep clean and to maintain and to keep on fire. So that's a huge one, and that's one of the reasons why I try and avoid for many patients crowns, especially the smile line, because a lot of people say I don't want the black line, which is that edge where the crown meets the gum and meets the tooth.
Well, I wish I knew you at the time, because
bless you.
I only had a tiny corner of the tooth fell off.
Wow.
And it's recommended a crown, and then he messed up the crown. I had an X-ray.
Really?
I had an X-ray a couple of months later, and it looked like bacteria got into it. So then he's had to redo the crown.
Wow.
Yeah, so I went through absolute trauma. It was terror over that period. So yeah, I wish I knew you at the time. So,
but then again, right? Everything happens for a reason. Maybe you wouldn't be doing these podcasts if it wasn't for that experience. So you're sharing your life's experience to help others to avoid that. That's kind of one of your callings, right?
Yeah, potentially. Yeah. In terms of what I think we should do here, because I was going to ask you about like toxic materials to avoid, but maybe we wrap that into the second part, which will be cosmetics. Should we move on to part 2? Are you happy to do that?
I am, other than I think we should end with a big hot topic, and that is when you have a tooth removed and there's this kind of push towards having a dental implant, there's now a move towards avoiding metal implants. So it's this kind of discussion of, should you have a titanium implant or should you have a zirconia implant? And if you're online listening to biological dentists and holistic dentists, there's no dentists in that of that ilk that are saying get a titanium one. Yet if you go to mainstream dentists, the majority of implants that are recommended and promoted are titanium. So I sit somewhere in the middle, where I've not really seen horrendous problems with titanium implants, and because they are metal and then the tooth is fixed into a metal system, those joints and those attachments can be made much more tight and let's just say mechanical, whereas the zirconia ones, it's glass against glass. It just has a little bit more friction and a bit more trickiness to kind of work as a mechanism. But at the same time, biologically, zirconia is one of the closest man-made products to bone and to teeth. So, and as I think the biological dental movement really want to avoid electromagnetism, and
Yeah.
I support that too. And I'm well aware that if you have a titanium one, and many people have titanium hips and knee joints, and many of them have had them for 50 plus years, and we haven't seen horrendous problems to the point where we're now saying we must stop all these different metal implants and metal joints. But at the same time, there is a bit like the root canal story. You'll hear people who say, wow, since I had my titanium implant taken out and a zirconia one put in, I now feel so much better. So again, is that placebo? Is that real? All I can say is there are plenty of stories of that happening. And so the dentists that are doing that kind of work have lots of testimonials, and they're genuine. I know they're genuine. I know a lot of these dentists, and I do trust these dentists. They are not charlatans. They are doing amazing work for people that trust that journey and trust that process. So thank God they're there, but I'm not convinced they're necessary for everybody. And again, it just depends on so many other factors, on how sensitive you are. And I do find that people are interested in biological and holistic medicine. They tend to be very sensitive people. They have very sensitive immune systems, and they tend to be very stressed people, or they tend to be high achiever people, or they have a lot of immune system disorders. So if you can take away an electromagnetic stress or a focal sepsis stress, I'm sure that's going to really help people. But all the people out there that have got beautiful dental implants made of titanium that are healthy and look amazing, should they be removed? Again, that's where I sit on the fence and say, I don't think so. Well, when I say sit on the fence, I'm open to the possibility of it. Let me examine them, and then maybe say to them, well, let's screen you every 6 months or every year. Or you come to the practice, you see someone in the practice every 6 months to every year. And most wise patients see a hygienist once or twice a year, and often the hygienists can do that. They have the discussion, they look at the clinical aspects of the gum attachment, and if everything looks healthy and the patient is asymptomatic and they are healthy, they don't have any weird health disorders, then why are we intervening? So that's why we've got to be so careful. You get all these faddy ideas, in nutrition and in healthcare, and I'm not convinced it's for everybody, but it is for some people. And that's where a quality conversation that is truly holistic. To me, holistic means you listen to that person on that day, and then you listen with new ears the next time you meet again. You don't color that follow-up conversation with too much of the past. You just are back in the present moment, listening and diagnosing and investigating with fresh eyes, like a proper detective, right?
Yeah. No.
Yeah, and it is hard when you're in a rush, and that's what medicine generally is having a problem with. The NHS is in a kind of a crisis. Private dentistry is getting more expensive, so time is money. So we could spend half an hour, we could spend an hour being an investigator, and if you're willing to kind of fund that, then why not? And on the NHS, you can get that free of charge if you're lucky, but in the private sector, time is money. So do you have a half-hour examination? Do you have a 1 hour examination? Do you need more time? Do you need more tests? Just like with medicine now, all these extra tests in the private sector are getting very expensive. More blood tests, more scans, CT scans. If it's on the private sector, it just keeps on adding on the fees. So again, you've got to be clear. Are you willing to go down that financial road, let alone the time and energy road? So lots, as I've kind of tried to really color in tonight's discussions, it's not black and white if you've got complexity. It's black and white if you are literally black and white. You've got just no problems at all, or really obvious broken problems like a cracked tooth that you got hit by a car or you're hit by a hockey stick. That's black and white. But we're talking general routine examinations where we see all this old dentistry, we see all these infections that are asymptomatic. And when I say old dentistry, we see hairline cracks in teeth, and we think, should we leave this any longer? This tooth might split, might fail, and we might have to take it out because we've left it too long in its current format. No different to an MOT in a car, like the car mechanic is constantly thinking, will this car survive another year with this MOT? And will there be really life challenges with the brakes, with the engine, with the clutch, if we underdiagnose, if we call it that? Yeah. So you can underdiagnose with dentistry, and the only way to kind of support less intervention is more regular screening. And
Yeah.
same with and I always say it's the same as the car. Your MOT is every year, but you might need to go and see your mechanic every 3 to 6 months just to tweak things. If you're holding on to something quite old, like a classic car or an old engine, etc., etc. Okay.
Yeah. I was going to ask just a really quick one. So, what is the longest? Okay, a few things. What's the longest you've seen a filling last? And is there any advice you'd give for people to get longer out of a filling? And
Good question. Yeah.
what's the longest you've seen a crown last? And again, what is the advice you would give to make that last? As long as possible as well.
Okay, so the simple, quick answer to all that is make sure you've got a quality dentist, right? And how do you know? Well, that's where you have to cross your fingers, because if you like your dentist and trust your dentist, then you'd like to think they can do dentistry that lasts. Sounds a bit unfair on newly qualified, but if you've got a dentist that's got X number of years experience and they have a good reputation, then you're increasing your chances of longevity for sure. If you go into experienced hands, that's no different to any profession. And I think word of mouth and your own instincts have got to have a huge part to play in those. Then on top of that, in terms of longevity, I've seen 50-year-old fillings, 50-year-old crowns, and these are people who don't necessarily have their teeth protected, but we do believe that if you put more protection into your bite, you're less likely to crack your dentistry, and you come regularly for bite checks and bite adjustments. So going back to the car analogy, often in an annual service, the tracking, the wheel alignment's looked at. So that's what we call bite analysis or jaw analysis. And so we can look if the bite has changed over the year, and if one tooth is suddenly getting overloaded, then we can kind of make adjustments accordingly. So that gets screened in a quality examination. Most dental examinations are not just about tooth decay, gum disease, and mouth cancer. Certainly experienced dentists are looking at the biomechanics as well. So that's one of the key factors in longevity is biomechanics and balanced movement or articulation or forces through all our teeth. And if we can't do that, or we're still vulnerable because we've got strong muscles, we're really big and strong and bulky in our jaw muscles, then putting in bite guards and bite protection. So a lot of people these days sleep with gadgets or pieces of plastic and rubber between their teeth to reposition their jaws, to turn their musculature into a more passive format. Also helps with a lot of snoring issues. If the jaw is brought forwards, the tongue comes forwards, the airway is opened, and jaw muscles generally tend to be more passive because we're not gasping for air as much. So a lot of people use a lot of muscles to breathe through their sleep if they are with sleep apnea or with some form of snoring. And it's often linked with sleep apnea when you snore. So to get that oxygenation, there's a kind of an excessive kind of movement of jaw musculature and upper body thorax musculature, neck musculature, just to suck in air to get well oxygenated. And even in spite of that, a lot of people wake up tired, so they still haven't got enough oxygen. So it's quite tragic, really. Yeah.
So you've seen 50-year-old?
Yeah, definitely. I've seen 70, 80-year-olds who say, yeah, I had my fillings as a child, and they're still there. They're as rusty as anything. Back in the day, we would polish them because they looked horrible. They were black. And then we'd polish them and rub off a lot of mercury off them and turn them into shiny ones. And that we were trained to do that, polish, and every year you just buff them up, right? So you're removing that surface corrosion. So that would increase the longevity of a metal one. And then the white ones, going back to what we said at the very beginning, just sometimes treat it like fiberglass or like decorating, where you're not going to redecorate the whole wall, but you're just going to rub down a couple of cracks and seal the cracks and just touch up certain areas. And you can do that with all these bioceramic products, especially the composites, the white filling materials. You can add on top of them. So you can rub a bit down, add another bit, and that's true restoration. You're re-restoring the old fillings. And that definitely then increases the longevity, because the bite surface of all these resinous products, they could be up to 95% ceramic particles, but that 5% of resin does biodegrade. And if you just every 5-10 years just resurface, a bit like road, bitumen pothole management, etc., rather than dig up the whole road and start again. You're just kind of keeping an eye on where the potholes are and filling them up quickly, not waiting for them to become big craters. So I do that. I've done that for 25 years, and I've kept fillings going in my current clinic 25 years, plus the previous clinic I was there 5 years. I've got at least 30-year-old studies, so I've got fillings of over 30 years of age, but they've needed a bit of maintenance. But what doesn't need maintenance for 30 years, right?
Yeah.
So even paintwork, you occasionally just have to just touch it up, and you get a little bit of rust in the bodywork of your car. You just rub down that rust and use those top-up paints, just to keep the metalwork kind of from bubbling up and flaking, and the paintwork flaking away.
What about implants? What have you seen implants last as long as this, or?
Yeah.
Oh,
And what keeps an implant is hygiene. Is very much well, when I say hygiene, it's biological status, and if someone has lost their teeth because of a poor biological status, then their implants can fail either straight away, or within a short period of time. And some surgeons will take a risk on them with a waiver saying we can't guarantee them. Whereas if someone has got a really good biological status, maybe lost their teeth through trauma, or through they had big fillings as a child and the teeth eventually just gave up the ghost, or fractured, or had septic root canals, etc., those people have generally a much longer lifespan with their dental implants than someone who's lost all their teeth because they smoked too much in their teens and 20s and 30s, and had maybe a hedonistic lifestyle with drugs and alcohol as well as smoking.
Because they could have like demineralized bone in the jaw, and the sockets of the teeth are like loosening through like.
Exactly. Yeah, they've lost a lot of bone and they need grafts. The more you graft, whilst it does work, it can work, they can fail too. If you've already got enough natural bone and you've been healthy most of your life, if not all your life, then the body does take dental implants. That's why they're so popular, because a bit like laser eye correction, it just works. But it does depend on who's having the work done. And in this day and age with economics now, some people are making decisions on people that probably 10, 20 years ago they wouldn't have taken a risk on. But, there are economic forces at bay sometimes. And if patients are willing to sign a waiver, then maybe they deserve a chance. But you will see failure.
I didn't know this till literally about 2 weeks ago. When people get the full dental implant, it's almost like the dentures are implanted and there's like 4 restoration sites, top and bottom.
Yeah.
I didn't realize that these teeth have like an artificial gum at the top of it. So when you lift up the lips, you'd be able to see where this fake gum meets the real gum.
Yep.
That is freaky. I didn't realize that was a thing. I don't know what I thought happened, but.
Well, it's mainly for hygiene, because you need sluiceways. You need natural saliva flow to wash around those 4 rods. So basically, there's usually 4. They can be 6, sometimes 8 of these. Often, well, I'd say the majority are titanium based, so they're metal rods sticking out from they're planted in the jawbone. Then attachments are then screwed into that, like little screws that are attached into the implants, and then the prosthesis is then screwed into that. And some patients are given the opportunity to take them out themselves, but the majority they're anchored in by the dentist. And because of that, we don't want people coming back every day. So we want patients to be able to self-manage with water flossers, with mouthwashes. When I say mouthwashes, like salty water, not necessarily the chemical ones, but just kind of regularly bathe and allow, more importantly, their own saliva to flush and flow underneath these metal attachments, because they can get gum disease just as equally as teeth can, because there is an interface between gum and bone with a metal rod that's screwed in the jawbone. And I would say there's more success with that kind of treatment than people having implants put between teeth, because when you have your own tooth adjacent to an implant, that's really quite a weak zone, because you've got like an artificial product next to a living system with ligaments. Whereas if someone's had all their teeth removed and there's 4 rods or 6 rods put in their jawbone, they're a lot easier to maintain. So that is when I do say to some patients, now's the time just to cut your losses and have your house knocked down and rebuilt. It's not really that many people, but there's enough. I've had enough conversations in my career where I've held people's hands for a certain period of time, and then it's like, now I think over the next year, next 1 to 5 years, go and get ready for this big move, because it's coming, right?
Yeah.
And there's only so many visits, using the house analogy, there's only so many times you can kind of replaster a damp area, right? You just, or there's subsidence, and you just kind of keep pouring down the plaster, the concrete, but the tree roots are still growing in, the whole place is moving, and the subsidence is getting worse and worse. There is a time when you just realize, now's the time. When I say now, within the next period of time, whether that's a year, 5 years. So for a lot of people, it's making the decision. That's the hardest thing. It's easy to make a decision when you've had a car crash and everything's smashed up. But when things are kind of failing, but still okay and still comfortable, but not really, we are constantly holding people's hands, because it's a big financial decision. And I would say the biggest factor is emotional. Letting your teeth go is horrendous, emotionally. And teeth represent so many things, from virility to how you look and your appearance, your fortitude. There's just so many kind of social stigmas attached to lack of teeth, shall we just say. So whilst we can help people emotionally, and then really good clinics are really well skilled at holding people's hands, in the patient's eyes, it's still a horrible journey. They love the end result, and they all want the quick end result. And this is where another dangerous game is being played, where it's all being rushed too quickly. And then that's where we are seeing new problems, because people are flying to other countries, just getting all done over a weekend. And then we're just going, oh my God, this was just done too quickly. You can do a lot of things too quickly, and certainly in dentistry. And that's a whole hornet's nest and a half. So, yeah. Maybe we talk about that a little bit in the cosmetic one.
Yeah, I was going to say, if we, when we do the cosmetic one, I guess we can talk about the horrors of flying to other countries and all of this stuff. But no, for part one, that was wicked. Yeah, really happy with that. And we'll move on to part two.